what I wanted to do was kind of, I'll give you a very quick spiel on where Aboriginal health is, like, you know, all the stats and stuff like that, and where it's up to. But I'd really like to talk to you about some of the emerging stuff, some of the innovation, some of the things that are well outside of health that we need to think about, that impact on health and impact particularly on what I'd call the narrative of Aboriginal and Torres Strait Islander health. I just like that. That's great. This is I also actually wanted to acknowledge Tom Kalmer, who's down the front here, who makes young people like me go and do these things. Actually, I'm not that young either, so can't use that anymore either. Look, the NACCHO definition of health. NACCHO is the National Aboriginal Community Controlled Health Organisation, and it's been around for a while, and had this kind of a view of holistic health at a community level. And I've gone through a lot of literature and looked at a lot of different things over the years, but I actually keep coming back to this one. It's probably one of the best kind of, the best ways that you can approach health in Australia if you're a health professional. So it's not just about treating people, it's not just about treating diseases, it's about helping people at the end of the day. And that's kind of what we sign up to as health professionals. I will go fairly fast because there's a fair few things to cover in this as well, so I'll try not to lose anybody or myself. The life expectancy stuff, everybody's kind of aware of this stuff now. So it's, you know, somewhere between 9 and 11 years less than the rest of Australia. And that's the calculated life expectancy kind of approach to looking at this. All the usual leading causes of Indigenous excess mortality around circulatory diseases, injuries, etc. Now cancer's kind of starting to get up there as well a bit. There's been some improvements in particularly life expectancy in a few of the different states and territories, probably based around better primary health care, I think, and as a result, better treatment and management of chronic diseases. So it's not all doom and gloom. There's some good things happening in Aboriginal and Torres Strait Islander health. And then down the bottom there, you'll see, you know, the risk factors. This is from the Institute of Health and Welfare. So, these kind of things, I want you to think about some of these things because, you know, we all call it the SNAP approach, the, you know, stop smoking, better nutrition, decrease alcohol and more physical exercise. But I'd like to challenge that as well, and I'd like us as health professionals in the Australian health system to challenge that a bit as well, because what I find is that by the time people are middle-aged adults who are overweight and got type 2 diabetes and heart disease, beating them over the head's not really helping anymore. We kind of got to get in a bit earlier than that, I think. There's some really interesting stuff around this. I was looking at life expectancy internationally. This isn't a very good table, but I used it because it was from the CIA website. The CIA collect this. And then I found there was a CIA kids zone. It's like, let's play Guantanamo Bay or something. I'm not sure. I didn't go into it much, but I just thought, wow, they collect some really amazing stuff. But this is just kind of showing, there's better charts than this that you can get from World Bank, etc. But and generally Australia rates about number 2 in kind of life expectancy, equivalent with a whole lot of other nations. But US ain't doing that good, but there's not that big a difference overall. And Aboriginal and Torres Strait Islander people are down the list there as well. This is the stuff that you've probably seen a little bit of. So this is the population graphs. It just shows that, you know, the Australian population is generally fairly stable with kind of younger, middle-aged and older people. And the Aboriginal and Torres Strait Islander population is generally younger and better looking than the rest of the population. And this is where the burden of illness happens. Basically, it's that kind of middle-aged blowout there. One of the issues for us, like, you know, as the rest of Australia is gearing up for an ageing health, an ageing population and aged care kind of facilities, we're still not anywhere near that yet. And what we're kind of worried about as people start living longer is probably more the middle-aged group that have chronic diseases and a blowout around those. So it's kind of, when we're looking at the future of the Australian health system, we're probably looking at planning for two separate kinds of things. This is Queensland data and from Queensland Health. This one's probably the most interesting slide. This is the distribution at death. So this is the ages that people die at, and you can pretty much see the very different distribution. Easiest way to remember this is that non-Indigenous is kind of like a martini glass, and we're kind of like a midi. Even the colour's right almost. So, but that kind of shows you a better kind of idea of the patterns. And this is just saying that rural and remote and urban do have kind of different profiles as well. So, and this is once again Queensland data that just shows that life expectancy is a bit less in the rural and remote, and there's good reasons for that. This is some of the risk factors, and also shows that rural and remote kind of have some high levels of the usual kind of risk factors: obese, overweight, tobacco, physical activity, etc. The data, I give this slide to the Institute of Health and Welfare and ABS. This is another way of looking at things, and this work, Alex Brown from the Baker, another Aboriginal doctor, had been working on for a while, and I've just taken it a bit further now, and it's starting to look at some of the other things. What is the narrative about? Is it just about people smoke too much, drink too much, don't exercise, and eat the wrong food and all that kind of stuff? And no, probably not. So these are the kind of more developmental ways of looking at some of the things, and particularly in some of the things that we know around epigenetics, early childhood experiences, and a whole lot of information that's coming out around those. So I just wanted to put that up there to kind of give you a bit of an idea, and I'll go through those very, very, very briefly because there's a whole lot behind all of them. But this doesn't discount personal agency, so people have got to want to stop eating bad food, and they've got to want to start exercising, all those kind of things. That's fine, but there's a discussion paper on empowered communities, which is a new national kind of policy that the government's looking at for Aboriginal and Torres Strait Islander affairs. But in that, they make this interesting observation that I put down the bottom there, that if you took a deficits approach to this kind of stuff, in actual fact, Aboriginal and Islander people make up about 14% of elite sports people in Australia, so the deficit is with you guys. You're 10% behind us in personal motivation. But that's not the way this is about, well, what are the causes of this? Are there intervention points? And for all of these things, there are intervention points, so it's not like, I want to throw things out there and say, well, we don't know what to do about it. There's actually some really logical things. This is just kind of doing a bit of a flow through of where things come from. And once again, I'm not saying there isn't personal agency involved in this, but there's a whole lot of things that have been in place that bring us to where we are today. And once again, this isn't a kind of, let's just blame the history and blame the past. This is just the evidence, That's what happened. This is where we are. That's pretty much it. And I'll go through some of these things once again, and how we get to these things here, like how we rebuild some of our communities, how we rebuild social norms, how we go about a whole lot of other things. And we have these big macro policies like the rights of Indigenous people, etc., that can help with that as well, and they are useful. I'll go through a few of these one by one now. That was Michelangelo's after he got back from Supersize Me. Oops. So the epigenetic stuff, there's probably people here who study genetics and epigenetics, so will know a lot more about this than me, but the basis of this is that, kind of environmental in uterine influences pull and push switches when you're developing, and have an influence on your phenotype, so when you come out. And they can set you up for the kind of conditions that your body thinks is going on outside. So if mum doesn't get enough to eat, it'll be saying, look, you need to store fat when you get out there because there's not much around. And so people get central obesity later in life. And so some of these things are heritable, so they're not genetic changes, but they're heritable across generations. So it means that if we want to stop some of these things happening, we have to start now, and probably in early childhood and in antenatal care, so that we can stop it going across generations. Microbiome, this is one of my favourites. Everybody's seen the stories, the research with the fat rat, and they give the fecal material from the little skinny rat and they put it into the fat rat, and the fat rat gets skinny. That's enough to make you lose weight, just thinking about it. But this is about, so the microbiome is all the bugs basically that are on your body that you're born with, or that colonise you through your gut and everywhere else. And for a long time we didn't realise how much of an effect, a metabolic effect, the microbiome has on things like type 2 diabetes and obesity, etc. And we're only finding that out now. And for me, the kind of reflectively around Aboriginal health, every time you do something like take an antibiotic, etc., that influences that in a huge way. And this can be mapped now as well. But and I kind of started thinking about, heaps of our kids, they'll have, skin infections, throat infections, all the rest, and kind of have the 4 food groups and antibiotics kind of as the kind of next most common thing. So what this is doing, we don't know. So we're trying to do some studies now looking at which kids got lots and lots of antibiotics as they've grown up for skin infections, ear infections and all the usual things, and if it's had an effect. But the fact that now we have 12-year-olds and 10-year-olds with type 2 diabetes, that we have no idea where this is going or where it's coming from, is a bit of a problem. And in actual fact, in places where I work like Cape York, so we have an endocrinologist that can take care of the adults with diabetes, and we have a paediatrician that can take care of the kids, but neither of them have any experience in taking care of little kids with type 2 diabetes. So we're behind the 8 ball there a bit. This is stuff from McEwen. It's really worthwhile looking up some of this stuff. McEwen's a physiologist who's done a lot of this stuff around what he calls allostatic load, but it's just the sum total of the stresses that are on a particular person or an organism. And the responses that we have from that. So it fits in with a lot of things from psychotherapy right through to trauma and abuse and things. But basically what he's saying is here is that usually when we're looking at behavioural responses and personal responses, we look at these ones here, the SNAP kind of stuff. But in actual fact, it's probably a bit late then, and we need to start thinking environmental stresses, major life events, trauma and abuse, etc., and how that affects these kind of things as well, because it's part of our adaptation to those kind of stressors. Really interesting stuff to look at. When we started looking at how we might run a health program up in Cape York, we kind of went right back to the basics, as to what do people really need? What's everybody need? This crosses cultures and everything else as well. The Maslow stuff is just the basics. What's everything we need? This is probably closer to your hierarchy of need now. And this is a really interesting. You can Google most of these things actually. The Adverse Childhood Experiences, the ACE study, I think it's been carried out now by the Centre for Disease Control in the US, but it's a longitudinal study, and it compared people who had a whole lot of adverse childhood experiences, as named there, household dysfunction, sexual abuse, exposure to different things, and then looked later at later life outcomes, and they found these very, very significant increases in these outcomes, including chronic disease, obesity and drug and mental health issues. We did a screen up there of one of the schools with all Aboriginal and Torres Strait Islander kids, and we found 60% of that. And what you'd expect in kids from about 13 to 18 years of age is that they'd be pretty healthy, maybe STIs, that's what you'd look for. In these kids, they over 60% had very, very, some of them had extreme adverse events, like they'd seen their mum get stabbed to death in front of them, stuff like that. So not a single one had been offered any counselling, interventions or anything like that. And actually they were really open to having that kind of stuff, and probably even worse still, it didn't seem abnormal to them that they'd been exposed to some of those things. This is just the data from the Western Australian Child Health Study, just saying basically the same thing but at a larger level. This has been studied now pretty well. Generally, extraordinary levels of stress in early children and in the carers for early children. That one as well, that's Fiona Stanley's group over there, and that's all easily, you can download all those reports as well. Footprints in Time is a longitudinal Australian study that the Australian government's doing on Aboriginal kids. They're up to wave 4 now. And once again, it tells us kind of the same story. One of the interesting things I found about this was that all this stuff that I thought would be the worst high score for stressors for these kids, drug and alcohol and all the rest of it, weren't. They were kind of less high. There were others there. Trouble with police, being cared for by somebody else, etc. This is just to show that, from a developmental perspective, it's not just stressors in early childhood, but it's sustained stresses, and that's what this shows, that across all the waves, as they follow these kids through in age, a lot of these stressors were sustained, so that means we have to do something about that. It's kind of like, when you have the fight or flight, response? Well, it's been switched on all the time, never gets switched off. That's just some of the things that were the stressors, and the other one was the longitudinal study of Australian children, just as a kind of a comparison. This was really weird. This I don't quite understand this yet, but this is comparing the footprints in time, the carer's satisfaction with a whole lot of things, and the household's income and something else study, the elder study anyway. And they asked pretty similar questions. It's always hard to compare these, but similar questions. But the interesting part here was that Aboriginal carers felt safe more often. They felt more satisfaction in the community they lived in. They felt more satisfaction around health and around relationships and a number of things like that, which is kind of goes in the face of what people's social, and demographic kind of background looks like. But there's probably good reasons for this as well. And I think some of this is kind of to do with these kind of cultural or cultural influences or cultural determinants, as some people call them, as well, that there's a whole lot of more relational stuff involved. Anybody heard of Rat Park? So this is about addiction and addiction medicine. So there's a whole lot of work being done on this at the moment, particularly in remote Aboriginal communities, alcohol management plans, etc. This guy was a guy that, and don't get me wrong, this one hasn't got great evidence behind it. I don't think it was replicated very well in subsequent studies. But this guy was involved in the original experience when they put rats in little cages and they kept drinking the morphine drink instead of the water drink. And then he said, what would happen if I made a nice little rat kind of park and put them all in there with their little kids, little rat kids and little rat families, and had little rat condos and stuff, and lots of things to do and play with. And then I offered them morphine water and water, and about 95% of them didn't choose. They tasted the morphine and went straight to the water and didn't bother with it. And he's kind of, what he's talking about there is just saying, look, there's a whole lot of environmental things as well here that we have to look at. He's from Canada, so he's been applying that to some of the Canadian Aboriginal reservations as well. But this happens in other circumstances as well. So I'm not saying this is good science, but it is an interesting phenomenon. Poverty thinking is something that we completely forget about in health, and I'm not sure why, because when we look at socioeconomic gradients, we know that poorer people make worse health choices than others. For a while now, the economists, some of the leading economists internationally, have been doing some of this work around this, and they're actually saying, the choices they make are very rational and very logical given their income and their circumstances. Esther Duflo is worthwhile Googling. She does this stuff from MIT. She's an economist in the US and does a fantastic talk on this, the interaction between hope and poverty. And David Campbell from Central Australia has studied this as well, and he's published on this. And he's just saying there's actually some good reasons for choosing things when you don't have as much money or portable income as other people. And the kind of theory is, thinking about the future may not be a great thing if you're living day by day. So, you can kind of apply this as, why is the young mum with 4 kids who's on a pension buying a flat screen colour TV at, whatever it is, 50 cents, I don't know how big they are, big ones anyway, instead of using that money on saving up for a trip to Bali? Well, she's never going to go to Bali and she's never going to get a house. So why would she even bother trying to do that? And it's just kind of saying that from an economist's perspective, that there are other ways of looking at some of this behaviour. We took Margaret Chan, who's the head of the World Health Organisation, up to one of our communities in Cape York, and the thing that she said on the way back was, the thing that I noticed most is just a lack of hope. And if health services and health professionals can start engendering hope in people, I think we'll go a long way to helping. This stuff's really interesting. Youth bulge, it's this guy Richard Sincotta, who's a US demographer. He predicted the Arab Spring purely by looking at the demographic base of different countries over there. And basically what he says, if people are older, the country's, if people are all old, the country becomes economically non-viable because there's not enough kind of input. If it's a nice one like Australia is, you have pretty good balance and you can stay viable. If there's a big youth bulge though, and they don't have access to education and employment and other things, there's going to be a riot and there's going to be civil unrest and a whole lot of other things. And so our demography, the Indigenous ones, probably closer to Tunisia or Afghanistan around these kind of things. The thing that I think about this, though, is that We have a whole labour force. We have a whole workforce of young people. We have a whole lot of young people who could be activated, you know. And I think about things like, you know, man, if our Aboriginal young people are out in the streets marching, demanding education and employment and stuff like that, I think that'd be fantastic. I just put this one there because I like it, it cracks me up. The social determinants most people know about, and I've kind of covered on them, but I just wanted to throw it in there because everybody talks about social determinants, so this is kind of a little bit more. So as future health leaders, health systems level stuff's going to be really important, I think, for the country. This stuff we've been working on has been around the value in healthcare, and this guy's the guru in Harvard is Michael Porter, I think, and he's been looking at a whole lot of these things and how we measure this, and how we always in health measure proxies instead of measuring the real outcomes, and think that's going to be a good thing and that's going to give us the outcomes we need. And this goes as well because I think this is one of the things we can apply to the whole health system, whether it's private practices, whether it's physiotherapy practices, whether it's nursing, whether it's medicine. This idea of value, and basically it's not a code word for cost reduction or cost cutting or anything like that. It's basically, does the money we put in give us health outcomes? And I mean proper health outcomes. Not just do we apply the best practice guidelines or the clinical guidelines to what we're doing. So some of these things I think are really important for us. As the health, you know, the health reforms have come from RUD, which was the Medicare Locals and Health and Hospitals Boards. Now they're PHNs, etc. But once again, we kind of set them up as small businesses almost. And health gets left out of that quite often when you set up small business and corporate kind of practices. So we have to be really careful of that. I'm not saying it's bad, but I'm saying you have to have balance in all this or we'll lose focus on health. There's a whole lot of other things in there as well that are current government approaches, contestability, so whoever puts in the best application gets the funding to do a program. And look, you know, there's kind of super duper corporate practices that will put in better applications than I ever can. But they'll never be able to have the same effect as some of the Aboriginal community controlled organisations in remote Aboriginal communities. So they're the things that he says are really important from Porter. Those things, specification planning, microsystems, measurement and oversight and self-study. And they're all things that we should have in our health system. And I know some of the hospital boards are looking at some of these things now, but they're very, very important. And we try and apply them in our service. The national policy stuff, this is just a graph that I love that you should have a look at sometime. It's in a book called Social Epidemiology, but you can find it in other places as well. All this is saying is that life expectancy and income are related. So basically, the richer you get or the higher level of income you get, the longer you live until obviously it plateaus out, or Sheena Reinhardt would live forever. And then the kids would really be pissed off. But and what it's saying, I shouldn't say things like that anyway, but what this is saying is that the steep part of the curve is down here, where poorer people are basically, or the poor part of the country, the poor population in the country. So if you move this income stuff from there to there, you'll move this income stuff from there to there. Gina will lose 30 seconds of life. These guys will gain 2 years of life. And not only that, the average income for the country doesn't change, but the average life expectancy for the country changes. So it's just really interesting stuff. And Martin McKee, I'm not sure if you've heard him, he's a UK public health guy. So they've done these studies across the UK and Europe and basically found the same thing at a population level, where they say social investment or social welfare spending. So we're talking here about welfare, social programs and a whole lot of things that our governments are talking about at the moment cutting because we don't need them. They're the things that bring down the all-cause mortality. So where there's more social welfare spending in these countries, there's lower levels of all-cause mortality. So something to think about for any of you that do get involved in health planning or policy or politics. And this is just saying that Sen Amartya Sen, the economist, is one of my heroes. He's just done some of these studies as well. But Thailand's has put in place a universal healthcare coverage. It's very scaled down. It's basic access. their life expectancy is better than ours in Cape York now. That's Thailand. These things are doable. That's just saying that, you know, Australia actually at the moment, you know, in spite of the politics around this, and don't get me wrong, I understand the post-GFC and all the financial issues, etc., but we're still not spending anywhere near like a lot of other countries are, and we're actually getting better outcomes. I mean, that's just a healthcare ranking from perspective of other things as well, quality healthcare and access, etc. And we do pretty good, other than for the Aboriginal and Torres Strait Islander model. This is just show you that statistics can be a bit dodgy, you know. Have a look about it. You'll get it. You'll get it after a while. Internationally, self-determination. This comes from the Harvard Project on American Indian Development and a whole lot of American reserves over there. Self-determination is the only federal policies that made a difference to those Indian. Now, these are structures, and I won't go into this too much, but for those of you that do read kind of a little bit more outside of health, and think about things like capabilities, and Treasury Department bases some of its stuff now on capability approach, etc. There's a whole lot of things that need to be in place in communities for people to live lives they have reason to value. This isn't about just longevity. It's not just about affluence and income. It's about, are people actually fully fulfilled in their lives? And they're the kind of things that they've come up with there. So I mapped them against what's happening in present in our remote communities, etc. I also mapped against the Declaration of the Rights of Indigenous People, which has all these things in it as well, just to have a look. But so some of those things we have, and some of them we really don't have yet. So we need to put some structures in place if we want to get there. You've all heard of the Michael Marmot stuff and the Whitehall studies around control as a risk factor for cardiovascular disease. We've been looking at empowerment as one of the ways that we go about helping people to have more control and structure in their lives. And this is just a bit of a thing about community-controlled health organisations, which is what I work for, Aboriginal organisations that do their own health. They're not just about health, they're about driving civil progression in our societies as well. This is some really interesting research that came from Canada and looked at Aboriginal youth suicide. When they looked at the suicide rates across a whole range of communities, they saw in some it was really up, some it was really down, didn't know what was going on. So they looked at the normal things like income, gender, employment, and a whole lot of things like that, and that didn't make much difference either. When they mapped it against these things they call cultural continuity factors, where the local people actually had influence and some say in the services that were supplied to them, where there was more of that, there were less youth suicides. And if you aggregated them, where there was 5 or more present, it almost went to zero. This is amazing stuff around the suicide issues, particularly in our communities at the moment. So there's stuff there that we can build on as well. And that's just saying that this has also been trialled around type 2 diabetes, and it shows a kind of a weak relationship with that as well. These are the stuff we published up in Queensland for our community-controlled organisations versus private practice in Queensland around data that we'd co-collected, and just shown that our services did pretty good and did better in lots of process things, you know, around the right therapy, the evidence-based therapy and all that kind of stuff. And another one that just shows, there was a study that came out that said lots of Aboriginal people in Australia didn't access Aboriginal medical services because they didn't prefer to, and it was kind of a bit dodgy. But so we did it ourselves, and we looked at where people within a 30-minute radius of Aboriginal medical services, and they overutilised in that time. I won't do that one because it's a bit dodgy, but that's just another one to show you that we had zip drives well before everything else. So look, these are kind of some of the interventions that I think are useful. When big policies come through, like co-payments in Medicare and private health insurance and things like that, we've got to understand the implications for poorer people or more disadvantaged communities, because the implications are big for us, and we've got to make sure that they fit together. So any of you that get involved as become health ministers or whatever later on, prime ministers, they're the kind of things that we don't have at the moment. We never articulate big macro health policies with the close the gap and the other policies that we run. There's a few things around legislation, and that includes treaties and things like that. The early childhood approach and the epigenetics is really important, and I think our government's really getting that right now around a bigger investment in early childhood. And there's a whole lot of interventions that work that we know about that are evidence-based in that area. And the empowerment stuff as well, I think, is the other important thing as well. Economic participation, those kind of things. Well, health's actually a really, really big contributor to employment in Australia. One of the biggest contributors, so we need to utilise that. That's just saying that, you know, the Heckman kind of stuff where you invest earlier on in life, you get better outcomes, better bang for buck, basically. This is megatrends, and this is my almost final slide, but this is an Australian Health Review currently, and I think Ernst & Young or somebody did this study looking at, well, what are the big trends that are coming to the Australian health system, and are we ready for them and across them? And a little bit we're across them, not fully though, you know. Things I worry about though is, at the moment, what we use to get information for our health system policy is often the government outsources now, so we'll get a consultant to do a short, sharp piece of work and say, this works, that doesn't. When in actual fact, good, robust research, there's no substitute for that. And it's peer-reviewed, so it gets out there. And from my perspective, you know, and I sit on some of the committees that oversee some of the consultancies and stuff like that, whoever pays for the consultancy owns the work. So you can turn around and just say, I know what you wrote, but I don't like it, change it. And they have to, and they're under contracts as well, so they can't tell anyone. So there's a lot of different ways of looking at, but I think it is a worry if we swing too far into the kind of small business corporate health way. There's nothing wrong with it, but if we go too far that way, I think we'll have an inequitous health system. And these other things, it's worthwhile having a look at that study as well from CSIRO Publishing. But there's a few things here that we need to think about: rising consumerism, urbanised market, whether we're going to have a de-investment in rural and remote, and a number of other issues. So the future, I think we just, as I said, I think we know where Aboriginal health fits in. We need a more sophisticated understanding to why the poor health is there. We need to use more objective measures such as value and understanding whether our health system works well or not. Allowing the Aboriginal Torres Strait Islander leadership to lead is a really important thing within Aboriginal health. And the fact that, look, we've only had access to education in the last 30, 40 years. I mean, to any kind of education. So we're doing all right, you know. My last thing to leave you with is basically for you guys. In leadership, there's a couple of things. We talked about these things in a Pacific Rim Indigenous Doctors Conference in Hawaii about 6 years ago, and we were looking at what are the kind of things that that you have to think about if you're going to go into any kind of leadership. And I don't think this is related just to health. It's you as a person, whether you're leading a small team, big team. Knowing who you are is really, really important. And from a cultural perspective, we have to know who we are culturally. But you also have to know where you sit and what your agenda is, because if you don't, you'll get it ripped out from underneath you because somebody else will make that up for you, or make a narrative up for you. Knowing what you're doing sounds like pretty basic, but I sit on a lot of national committees, as do other people here, and you would be surprised how often we have no bloody idea what we're doing. We're looking across the table at each other, smart bunch of people sitting there, and we just don't know exactly what we're doing there. And know why you're doing it. Your personal agenda will come across at the end of the day, you know. And if you're not there for the right reason, or if you're not completely across why you're doing what you're doing, someone else will pull a rug out from underneath your feet once again, and you look like an idiot. So they're the kind of things I think are important. Thanks for listening.